Nothing's off limits with this duo. It's father and daughter, Don and Cher. And join the club if you're a chattermouth.
Hey y'all, it's Cher and
Dawn.
and welcome back to the Chattermouth Podcast. Today we have on my husband, Jared. Well, that's how I know him, but his patients know him as Dr. Jared Gopman. He is a plastic and reconstructive surgeon. He finished his residency at Mount Sinai Hospital in New York City, which is highly competitive. He did a 6-year program which focused totally on plastic and reconstructive surgery. I'm so excited to have him here today. He is an expert and fellowship trained. We have so many questions for you.
Looking forward to it. Let's get started.
All right, let's get right into it. First of all, can you tell me a little bit about how, I know there's lots of different people here in the United States and all over the world who perform plastic surgery, but I don't think they're actual plastic surgeons. Is that correct? I know that there's cosmetic surgeons that are doing breast implants. You've spent 6 years dedicating your life to this field, only doing this.
Yeah, that's a great question. So in Tampa Bay, this is kind of a big issue here. There's a lot of people out there that are doing these cosmetic surgeries because they're cash paying, you can make good money, they're sexy surgeries, and you can make people happy. You don't have to be a plastic surgeon, a specific plastic surgery surgeon that was trained in a plastic surgery residency to do these type of surgeries. In fact, sometimes in horror stories, you hear about doctors that are maybe internal medicine trained that are doing liposuction and having terrible complications, or dentists that are doing these surgeries, all sorts of things. There's a lot of people out there that call themselves cosmetic surgeons. And in the worst case scenario, I'm not saying this is for everyone, but in the worst case scenario, they have very little actual plastic surgery training. Maybe a few months, maybe 1 month, where they just focus on plastic surgery and these cosmetic surgery procedures, and they are doing them all around town. So you want to look for somebody that has the credentials, that went to a plastic and reconstructive surgery training residency program, and that has all of the training in plastic surgery, both from the cosmetic side and the reconstructive side, because you need to be able to do both. They're kind of both sides of the same coin. That is really important to be able to take care of patients, fix patients, and be able to have the best possible outcomes.
Wow. Well, I am so happy you're here because your episode was actually one of our most talked about, most liked episodes in the past. And so I think a lot of the people who listen to our podcast also enjoy some of the things that we enjoy, which is plastic surgery talk.
We
so
love
much fun.
all things to do with plastic surgery. So I have a million questions for you.
We haven't done that much. I mean, I've only had Botox, and you've done filler once on me, and then I did the Morpheus.
Right.
And that's about it that I've tried so far. But maybe one day, once I'm sure we're not going to have any more kids, we'll venture out into something a little bit more.
Well,
How would you feel?
You know what I always say?
What?
The only thing you need is cuteness reduction surgery.
Aw,
'Cause
thanks,
you're just
Jared.
too cute.
Aw,
Never too cute.
thanks, Mom. Well, she's always reading about plastic surgery, wanting to learn more. So I think we need to just get right into it. We've also had a bunch of questions. We've put on Instagram asking people if they have any questions about plastic surgery for you. And so let's get right into it.
Let's get to it.
Yes,
Okay.
yes.
Do you want to take it away?
Let's first talk about breast implants and breast reduction, all about breasts first, because that's like a big thing.
Yeah, a lot of people nowadays are actually they don't realize that when somebody has an implant, they need to get them redone. A lot of people don't realize that. Can you tell our listeners about that?
Yeah, so I think that since plastic surgeons have been putting implants in over the past few decades, we've gotten better at knowing the both short-term and long-term complications, and we've gotten better at counseling patients about how to manage their breast implants and what to expect long-term with breast implants. The most important thing to understand when you have breast implants is that they are not meant to be lifelong devices. So if you're a 20-something-year-old girl getting implants put in for the first time, you have to be ready for the fact that maybe when you're in your 40s or 50s, you may need another surgery to either remove them or exchange them for brand new implants.
Is there a time limit, like they say 10 years, and you need to remove it?
Yeah, that's an excellent question. That's one of the most common questions I get with women who have older implants. And it kind of depends. So I always tell women, there's not a specific date that your implants expire. If your implants have been in 10 years, 15 years, 20 years, but you still like how your breasts look and you like how your breasts feel, then you actually don't have to do anything. As long as you stay up to date with your surveillance for your breast in general, breast cancer surveillance like mammograms or maybe even ultrasounds, you don't have to do anything. So what does that mean? Well, number one, if you like how they look, that's easy, right? If you don't feel like they're too saggy, if you like how the implants have settled over time, and you feel like you like how your breasts look when you look in the mirror, both in clothes and also naked. The second thing is, do you like how your breasts feel, right? We want our breasts to feel soft, right? So over time, you can develop the most common long-term complication, which is called capsular contracture. And if you develop capsular contracture, your breasts might start to get hard. So if you don't like how your breasts feel because they're hard, then that's a reason to have your implants exchanged or removed altogether.
Are more patients more prone to capsular contraction than others? And is there a way to prevent it?
That's an excellent question. So that's been studied a lot. And we found that while there's multiple ways to put in breast implants, such as around the nipple, under the fold of the breast, in the armpit, or even through the belly button, which is not as commonly done, there are different rates of capsular contracture development depending on which way you put the implants in. It's actually been found that there's a decreased risk of capsular contracture if you put the implants in under the fold of the breast compared to around the nipple. So in young women who are just getting an augmentation, they don't need a lift or anything else, and you have to decide where to put the scars on the breast, all things being equal, unless there's another reason for me to put the scar around the nipple, I try to put them under the fold of the breast because I'm thinking long term. I want to decrease their risk of capsular contracture in the long term. But you didn't ask me, what is capsular contracture? What am I even talking about, right?
What is capsular
You
contraction?
didn't even ask. I didn't know you guys know so much.
I just assume it's when your breast gets hard.
Right, exactly. So whenever you have any sort of foreign body put inside of you, whether it's a hip replacement, a knee replacement, a shoulder replacement, or even a breast implant, your body forms a wall around it because your body says, this is not part of me. So let me wall this off from the rest of me so that I'm not interacting with it. So you can imagine that if you have an implant, the wall is kind of implant shaped. It's like a circular wall that's 360 degrees around the implant. In the beginning, that wall, which is called the capsule, is very thin and pliable. It's kind of like wet tissue paper almost because it's very thin, very pliable, like less than a millimeter or even a millimeter thick. However, over time, your body can put layers and layers and layers upon that wall and make it thicker. That thickness can even become firm and can displace the breast implant. So you might see someone with capsular contracture, all of a sudden their breast gets hard. But then as it progresses, that breast implant now sits up here, whereas the other one is sitting nicely. So at first, the implant can be a little bit firmer than the other side, or they can both be a little bit firm. And I'll say some women actually like that because that prevents the sagging that happens normally over time with gravity. So a little bit of capsular contracture, oftentimes women like.
So
they always say,
interesting.
I like this side, but it's the capsular contracture side. Severe capsular contracture can really make the implant go high. And then long term, the worst form of capsular contracture can be quite painful, actually, with difficulty sleeping on the side of the breast implant that has capsular contracture, or a tight squeezing feeling in the chest that feels very uncomfortable.
Wow,
Interesting.
that's
Wow.
so interesting.
Yes.
So with revision breast implants, when you do a revision, are you more prone to capsule contraction or no? Does the rate go higher with revisions?
Great question. So women who have capsular contracture are at a greater risk of getting recurrent capsular contracture after you take care of it. But there's things that we do to try and decrease that risk.
Oh, what is it?
Number
So
one,
interesting.
removing the entire capsule if we can. Sometimes if the implant is sitting below the chest muscle, the back wall of the capsule may be sitting on the ribs. And if that happens, it may be difficult to get that back wall of the capsule off without damaging the deeper structures like the lungs and the heart. So sometimes you have to leave a little bit of capsule. We try to get it all out. And oftentimes, even when it's under the muscle, I'm able to get it all out, especially if there's a thicker capsule, because there's a nicer plane to kind of separate. However, if you leave some of it, you are at a slightly higher risk. So what do you do in that case? Well, to decrease your risk of capsular contracture recurrence, you switch from the pocket of the implant. So if your implant was sitting below the muscle, now you put it above the muscle. If your implant was sitting above the muscle, now you put it below the muscle. So you switch the pocket, which can help to decrease the capsular contracture. Number 3, there's all sorts of cleaning solutions that we use that are medical grade cleaning solutions during the surgery to try and get rid of any residual bacteria that are sitting inside the capsule. Because the theory of capsular contracture is it's caused by possibly a low grade bacterial infection, not something that's going to cause an abscess or pus inside the breast, not something that's going to get you sick, but just enough that it causes your immune system to trigger that inflammation to thicken that scar tissue. So that's why getting the capsule out, which may be harboring some of the residual bacteria, and cleaning with multiple types of medical grade cleaning supplies that we are safe for use in surgery can help decrease the risk. Lastly, after your revision surgery, there's specific medications that you can be put on that are very benign, very safe to use, that we keep you on to help prevent capsular contracture from coming back. The medications can't reverse capsular contracture, but if there's somebody who has capsular contracture and you treated it, it can prevent it from coming back.
Oh, it's so interesting. Is there one place that's for aesthetics versus health that's better to place the implant? Like I hear like under the muscle versus over the muscle versus in between, half under, half over. Like there's so many different ways of putting it in. Like it's confusing. What is the best way for aesthetics versus health?
It's a great question. So there's definitely been a historical growth over time. In the beginning, we were putting implants above the muscle only. But then we were seeing very high rates of capsular contracture. So then they started putting the implants below the muscle because we found that by putting them there, the capsular contracture rates decreased over time. However, now there's a lot more of upper body exercise. A lot more women are doing Pilates, CrossFit, high intensity interval training or HIIT. And they're doing a lot more upper body. They're getting in the gym and they're doing a lot more weightlifting. And if you have your implants under the muscle, there's a much higher risk of something called animation deformity. You've all seen the bodybuilders, right? And when the bodybuilders are posing, they have very little fat because they're trying to get rid of as much of their body fat as possible. So they just have their implants, and because they want their implants to look as natural as possible, they have them under the muscle. And every time they pose, you can see those implants are moving.
Oh, that's interesting.
Every time the chest muscle squeezes against the implant, it causes what's called animation deformity, where the breasts move. So women are now more active than ever, and because of that, you have to take that into account in terms of whether or not you put it above or below the muscle. Because someone who's not doing a lot of upper body activity and who's very thin naturally, it will have a more natural look in the upper pole, which is the upper part of the breast, if you have it under the muscle, because the muscle covers the top half. So you have kind of like a nice, gentle slope. Whereas if you have it just above the muscle, then you get a kind of a bump, which some women want, and which gives you that nice augmented look, but other women kind of want to be more natural. However, if that same woman has their implants under the muscle, then they go to the gym and they're doing some chest press or they're doing push-ups or anything like that, they're going to see those breast implants in their tube top, right? And their sports bras that women wear to the gym now, they're going to see them moving around. And that's called animation deformity. So I always take that into account in a new consultation to try and decide which is the best place to put the implants.
Is there something in between, half under, half over?
Exactly. So
what is that?
So
I've never heard of that.
Excellent question. So there used to only be two ways to put the implants. Subglandular, which means below almost all of the breast tissue, like below like 99% of the breast tissue. And then submuscular, which means under the muscle. Okay. So those were the only two ways. However, in Brazil, they developed a new plane called subfascial. And it's a little bit technical, but I can take you through it. What that means is that every muscle has connective tissue that surrounds the muscle called fascia. Okay. Your chest muscle, which is the pectoralis major muscle, is the same way. And below the fascia is the muscle. And we found that by raising up that fascia, you can actually slide and create a new pocket to put the implant in. So it's technically within the muscle, but all of the muscle itself is below the implant. So what does that mean? That means that you have all of the breast tissue, all of the fascia that sits above the muscle, above the implant. The muscle is below, and it's still not higher risk of capsular contracture because it's outside of the breast tissue. You solve one of the problems that women are very concerned about, which is my implant going to hide breast cancer on a mammogram, right?
Right.
Have you ever heard women worry about that? Because that's one thing.
I haven't.
That's one thing that I get questions about is what happens when I get a mammogram?
Right.
Will the breast tissue that may have cancer be hidden behind the implant? And I will say that even in a really good subglandular pocket, probably 99% of the breast tissue is above the implant, but there may be that less than 1% that is theoretically hidden behind the implant. Not to say that the mammogram won't see it, because they usually do. But if you're worried about that risk, but you still want your implants above the muscle, the subfascial plane kind of solves that. So I really don't do a subglandular plane at all. If someone wants their implants above the muscle, I put it in the subfascial plane. If someone wants their implants below the muscle, say they're very thin, they want a natural looking breast, they don't want really people to know that they had breast implants, they just kind of want to look like they have nice, bigger breasts, and they don't do a lot of upper body activity, then I'll get it below the muscle.
That's great. Do you have your clients or your patients, bring in photos, or how do you know like what they're looking for?
Yeah, so it's an awesome idea to bring in pictures anytime you go for a breast augmentation consult, because I will say that 100% of women tell me that they want to look natural. In fact, the most common thing that I get is I don't want to look like Dolly Parton.
Interesting.
Everyone tells me I don't want to look like Dolly Parton. I want to look natural.
It's so interesting because years ago, everybody wanted to be big breasts, and now it's more natural looking breasts.
Right.
How times have changed.
The problem is that natural means a lot of different things to a lot of different people, right?
True.
So women will tell me, I want to look natural. But then I look at their wish pics of pictures that they took from the internet and of women with breast augmentation, and you can clearly see that they've had breast augmentation. So there's nothing natural about it, right? Because you can clearly see to a trained eye, these are augmented breasts. These breasts have implants in them. But to them, that's natural. So that really helps to guide what the women want in terms of both size, in terms of how natural they want it to look, in terms of how ba-boom they want to be. And everyone's different. So it's really helpful to tailor that. In fact, when I'm in the operating room, I actually put the pics up on the screen so I can keep that idea in my head of what the patient wants.
Oh, that's
I
wonderful.
love that. I love that you take the time to really look at what the patient wants and make sure you're giving that to them, not just what you think looks good. And something else I noticed that you do is you do sizers you use in the operating room. Can you tell people about that? Because I think not all doctors do that, and I think it's such an awesome thing that you do.
So what you mean by a sizer is a temporary implant that I put in during the surgery to make sure that it looks good. So
because I think a lot of people come in and they just probably say they want to be bigger. Like, how do they know what size to go? Like, if I was to go in and say, I want to get my breast done, it'd be hard to pick what size do I really want to be. I'd want to be a little bigger, but not like it's tough, you know? So I guess you have to be the one to really decide in the end what's best by taking what they want into consideration.
I think it's kind of a dual contract that we both sign. So I take into account what you want. I listen to you, but I can only promise you kind of a range of implants. On the day of the surgery, I order a whole bunch of different sizes with kind of a target in my head that I'm not exactly sure if it's going to be perfect. I think it's going to be exactly what you want, but I'm not sure. I then put a temporary implant, which is called a sizer, in. I sit you up in the operating room while you're asleep, and me and all the ladies in the room take a look at the breast implants. And then it's a little bit of a democracy to say, oh, is this big enough? Is this too big? Are they sitting the same? Is she going to like this? And I always have the final say. I will be honest about that, but I do try to listen to the women in the room because I think more eyes are better than just mine in terms of making that final decision. I then take out the temporary sizer and put in the permanent implant after re-sterilizing everything to decrease your risk of infection and decrease your risk of capsular contracture. So because of that, the surgery takes a little bit longer than some of my colleagues who maybe just throw in one implant that they decided before surgery. And that's why I can never promise exactly what size patients are going to be, but I kind of have a good idea and I give a range.
It's so wonderful how you really listen to what the patients want because, they're coming in and they want this change, but they have a vision of what they want. And you actually listen to them and try to create that vision and make it reality for them.
Yeah.
Look, ultimately, my job is to try and make people happy. I went into this field because it feels really good to be a surgeon that patients are happy to see. When I was going through all my rotations, surgeons normally in a lot of fields make people sad, right? Because they remind them of something bad that's going on in their lives and they don't want to have surgery, right? You have a tumor on your kidney. You don't want to have your kidney removed. You're sad to have that done. But my surgeries oftentimes are the fun surgeries, right? You want to get this done. Yeah. So happiness of the patient is super important because this is supposed to be fun, right? It's still surgery. It's still serious, but ultimately it's a fun surgery that will make you happier about your life.
I love that. That's
yeah,
so true. It's true. It's exciting to go into like the plastic surgery office. It's exciting because you're going to get something that you've always wanted. So
and
I think
build
that's
that
awesome.
confidence
Exactly.
in yourself. You know, you come out and you're so much more confident.
Mm-hmm. Something, we've talked a lot about implants, but how about a lot of people nowadays are getting their breasts done and they're getting lifts, but they're not getting implants, correct? How is that possible? Can they still have a lift and not have implants in? Or can you get your breasts done to look nicer without actually putting a foreign substance into your body?
Yeah, definitely. I think with the rise of the internet and how easy it is to spread information out, I think that there's been a lot of negative information about implants out there on the internet. And because of that, less people are going towards the idea of putting a foreign body inside of them, and more people want to be natural. Mm-hmm. So I'm doing more implant removal and lifts. I'm doing more lifts without implants, and I'm doing other things to increase the size of the breast, like fat grafting to the breast to try and help give that result without implants.
Wow.
I will say that nothing can increase the size of your breast and give you that big upper part of your breast fullness like an implant. Nothing else. But if you want to look natural, then and you have enough breast volume as it is, maybe it's just sagging down, a nice lift or a reduction even to be a little bit smaller can make you look tighter and more perkier, although you may be a little bit smaller. Because remember, I'm only taking away. Mm-hmm. In a lift, I'm just taking away skin mostly and keeping all of your breast volume intact and trying to just bring everything up. In a reduction, I'm actually removing skin and breast tissue to try and give you that perkier look.
Very interesting.
So they're similar, but a little bit different depending on what the problem is. Someone who wants a reduction is somebody who says, oh, my breasts are so big. My back's killing me because of these huge breasts. I'm having rashes under the fold of my breasts. And I don't like how my bra straps keep like digging into my shoulders. That's somebody who wants a reduction. Somebody who wants a lift is somebody who says, you know, I had children, I breastfed. Now my breasts are saggy. One breast is bigger than the other one, and they're asymmetric. And my areola have really spread out. So can you please... I want to keep my breasts big because I like my big breasts, but I want them to look tighter, more youthful, higher on my chest, and I want my areolas to be much smaller. That's what a good candidate for a lift. And I do both because they're similar.
Oh. Right. And how about a mommy makeover? I know we have a lot of moms who are listening into this podcast. So can you tell us about like what exactly does a mommy makeover entail?
Yeah, that's a great question. So a mommy makeover isn't one procedure. It's a general term for a variety of procedures that are combined together in moms. So usually you combine some sort of breast procedure, whether it's implants alone, a breast augmentation, whether it's a lift alone, whether it's implants with a lift, or whether it's implants, a lift, and fat grafting to the breast, along with some sort of abdominal procedure, which usually is a tummy tuck. A tummy tuck is super important in moms because of what the babies do to you during pregnancy and afterwards.
That's true.
Right.
And that's what's super important. I've talked about this on my Instagram, but there's a difference between what liposuction can do and what a tummy tuck can do. Because while liposuction just involves making tiny little incisions smaller than a pencil tip and using a cannula to suction out the fat, which we can sometimes combine with skin tightening devices under the skin to help tighten the skin, I'm not actually removing any skin with a liposuction. What I'm also not doing is fixing the six-pack muscles. We all have six-pack muscles, although in some of us they may be hidden, but they're all there. But what babies do is as they push through the belly, they actually separate those six-pack muscles away from the midline. And that gives you kind of a little bit of that boat-shaped look and gives you kind of that bulge that even with just liposuction, even if you have almost no fat on your body, you'll still have that because the muscles have now been pushed apart. So in a tummy tuck, not only am I getting rid of excess skin and fat, but I'm also going in, tightening those six-pack muscles back together in the midline to give you that nice cinched waist, which helps to really bring your waist in almost like a corset.
Oh, wow.
That makes sense.
That
I
does.
feel like
Because
that's really
all
good.
the amount of exercise won't do that. You have to have the surgery for that, correct?
Correct. No amount of sit-ups will fix that.
Wow.
But after you're nice and healed, you can go back to sit-ups afterwards and it will look much more defined if you
Wow.
combine exercise with surgery
Wow.
after 6 weeks.
That sounds great.
That is amazing.
Yeah.
I would have a smile from ear to ear afterwards.
Speaking of that, what do you think about, would you feel comfortable being able to do my mom's surgeries? Sorry to pause the podcast, but if you're loving our podcast, then you'll love our book, and we have to tell you a little about it.
Actually, we wrote this book, and it's about how we got this close and how you can too.
It's called A Bond That Lasts Forever, and basically it goes over our life's ups and downs. It shows pictures throughout our life and has adorable quotes throughout to inspire other mothers and daughters to have their own special relationship. You can pick it up on Amazon.com, at Barnes & Nobles, or wherever you get your books. Now, let's get back to the podcast. Would you do my mom's breasts if she asked you to?
Yeah, I mean, why not? If you really wanted me to do it, you're super healthy. There's no reason not to do it. And I assume you're asking because of
Like, would it be awkward? It's my mom. It's your mother-in-law. Would that be weird to you?
So at this point in my life, I've seen so many breasts and I don't get phased at that kind of thing anymore. To me, I don't see, I see the job. I see the art behind it. I see, the goals and the science. So I kind of am able to step back and take, it's not personal. It is personal because I would want to care more than anyone else who would operate on you. I think I would care the most, but I don't think I would be unable to do it because the awkwardness would be gone once I get in the zone of and put my plastic surgery hat on and I stop thinking about those kind of things.
Right. Boobs aren't like boobies to you. They're like art, which I think is really cool. It's like your work. It's your job.
Yeah.
Right.
It's kind of hard for sometimes because I am so critical of my results. And I don't realize that from a layman's person who doesn't see this and doesn't know the numbers and the science and the techniques, most people just look at boobs and they just go, nice.
right.
So they don't see these things that I see.
That's so funny.
I love it though. You are my son-in-law. But what I see in you is that you're so brilliant and you really hear what the patient wants. And you would actually hear me and try to recreate what I want. And to me, that's amazing. So I wouldn't care that you're my son-in-law because I want the best results. And I think you would be able to give me those results. Yeah. So do you want to go in together?
Oh my gosh.
You're the only one we would trust.
gosh.
Seriously, only one.
But then I'd have to take care of both of you because you couldn't take care of each other.
That's true.
So I'd be working at the office and at home.
Yeah, you're working overtime for us. That's
right.
amazing. That would be fun. Well, speaking of that, how do you know if you're like you are ready to get your breasts done? Like for me, you know, I go back and forth. Sometimes I think about it, and sometimes I'm not sure. How do you know if it's like time to get your breasts done?
Yeah, that's a great question. So the first thing I think you should do is see where you're at in your life. Are you stable enough that you can take time off of work for surgery in case you need to? Are you planning on having more kids in the future? Are you going to have help after surgery? And do you have somebody that can take care of you? Are you healthy enough to have surgery? Are you a smoker? Because if you are a smoker, which I know you're not, but if you are, then definitely no surgery for you. But if you check all those boxes and you feel like you could have surgery, the next question you need to ask yourself is, when you look in the mirror, are you unhappy with some specific part of yourself? Because patients come to me already with this idea in mind of something they don't like about themselves. They don't come to me and ask me what's wrong with them, because I would never tell you anything is wrong with you, because I think that's really mean how some people do that. A patient comes in and they say, you need this and you need that and you need that. But that's not how I work, because I feel like that really is a mean thing to do to somebody. You never want to talk somebody into surgery and tell them they need surgery. But if you look in the mirror and you really don't like something about yourself, then that's when you're ready. Most of the patients that come to me have already decided years ago that they didn't like something about themselves, but they were just biding their time, waiting till the time was right, till all of those boxes were checked, so that they can have the surgery done on their own terms. But if you are happy with yourself and you're getting some external pressure to have surgery from a partner, from people at work, from friends, or from some idea of society of how you should look and how your body should look or how your face should look, then those people are not candidates, because you are not doing it for yourself. You have to want this, and you have to do the surgery for yourself, because at the end of the day, this is your body. It's nobody else's body. It's nobody else's face. Nobody has to live with the results except for you. So do it for yourself.
Oh, I love that. Yes, I love that.
Yes.
Okay, well, we're almost going to wrap up here. But before we do, I wanted to ask you about scar care, because I know that's a huge part of surgery and, after surgery, because I would always get nervous. You know, you get these great breasts done, but what if the scar doesn't heal well? What if you don't heal right? Or if you develop a complication? What do you do, for example, if you do develop a complication? What happens?
Good question.
Those are two different
Yes,
topics.
sorry, I'm jumping around here.
It's totally fine. So on scar care, number one. So the first step in having the best scar is meticulous, delicate tissue handling. Making sure that you're gentle with the skin, you're not beating it up during the surgery, making sure that your closure with your stitches is perfect. Making sure that if the stitches do need to come out, you take them out early enough so they don't stay in too long, and making sure that everything looks beautiful. Then after that, it's a little bit of how the patient heals, right? Are you eating enough protein? Are you being careful to not do too much exercise too quickly? Are you keeping the area clean and not getting so sweaty? Or are you changing the dressings as needed? Or on the other hand, not touching them at all if you're instructed not to touch anything? Are you scratching and itching yourself? These kind of things can all cause a problem after surgery. And then after the initial healing phase, you get into the scar care mode. And really the data says that the only thing that has been proven to decrease your risk of hypertrophic or keloid scars is some sort of silicone-based product, either silicone gel or silicone sheets. And there's a myriad of products out there. My office has some that I think are very good, and getting started on those and continuing to use the scar care and perform scar care yourself is the most important thing long term. I always tell patients there's two things that scars hate. Number one is friction. So not rubbing the scars, not having your clothes rub on the scars, not scratching at the scars. And the second thing is sun exposure. So avoiding the sun on the scars at all costs. When it's your breast or your abdomen, that's not so difficult, right? But if it's on your face, making sure that you're using sunscreen at all times on your scars to prevent sun exposure, because any sun exposure is going to turn those scars red and angry. The last thing is scar massage. Doing some gentle pressure and massaging the scar can help to flatten the scar and soften it over time. And I always tell patients to be patient because scars take up to a year to fully mature. So the scars at 4 weeks, 6 weeks, when everything's healed, but you first see your scars, are the worst they're ever going to look. So just be patient, continue with your scar care regimen, and your scars will look better over time.
Wow.
Wow,
Very
that's really-
interesting. I love that. Okay.
That was a lot. And then the last thing you asked about is
Yes,
complications.
Complications.
Okay. So I was always told that if you don't have complications, it means you're not operating enough. So any surgeon who operates enough will have complications. It's just part of being a surgeon. What happens is that there's some things that are out of your control. You can't control everything. And sometimes complications happen. And sometimes that can lead to not as good of an outcome as you hope for. And that hurts. That is what really hurts the most, is when the outcome that you want is not the outcome that you get. But it's not about whether or not you get complications, because everyone gets complications. It's what you do after a complication happens. Okay. So I take call at nearby hospitals, and you'd be surprised at how many times a patient comes in after going to see Dr. Magic Knife or Dr. Sexy Surgeon down in Miami. They have their surgery because they saw the Instagram photos of these beautiful women. The surgery goes okay, but then within a week, they develop a complication. They call the surgeon's office, but nobody picks up the phone. The
my
surgeon
gosh.
basically just
Terrible.
abandons them. And it happens a lot more
Oh,
than you
it's
think.
Terrible.
How could they just, how can they do that?
I don't know.
That's
I don't
terrible.
know. They come into the ER because the surgeon doesn't pick up. They don't know what else to do because they can't travel all the way down to Miami when they're feeling sick. Or, I say Miami, but it could be anywhere that there's a lot of medical tourism. Dominican Republic, Turkey, New York, Los Angeles, anywhere. And they come into the ER because they don't know what else to do. And then, because I'm on call, now I have to take care of them, which I'm happy to do, but I never want to be that surgeon. So my patients will see me. I try to get them in as soon as I can if they're having problems. And then if they need to go back to the operating room, I try to get them in as soon as possible, because you don't want to let things linger, is what I've realized after doing this for a while. You want to get this taken care of because patients need the reassurance that you're there for them. Okay?
I love that you care, like you
Right.
actually care about your patients. And that's like so important that you actually get them in right away.
It's not
and
just a
you'll-
paycheck.
Right, that you'll actually make sure to even stay later to get them in and to take care of them immediately than to just disregard them because the surgery is done.
My biggest advice is when you're seeing a surgeon for consultation, ask the surgeon, what do they do if there's a complication? If the answer is, I've been in practice for such and such years and I've never had a complication, that surgeon is lying to you. And I've had patients tell me that surgeons have told them that. Because surgeons want to seem good. They're trying to sell you the surgery, right? Plastic surgeons are trying to sell, but it's not honest. And if somebody is telling you that, that's a little bit of something to be
flag.
scared about. That's a little bit of a red flag.
Right, right.
Interesting.
Wow.
It's what they do to help you after the complication that they should be looking for, it sounds like.
Correct.
Are they going to be there for you? I know firsthand if something ever is not perfect, Jared comes home and he's thinking about it. He's on it. He is talking to his patient. He is making sure they're taken care of because that's like his number one priority.
That's just as
Yeah.
important as having the surgery, because sometimes things happen and you have to know that your plastic surgeon is there.
Right, and it's a lot of times it's not the plastic surgeon's fault. It's just how you happen to be
No.
Right,
healing,
right.
or just how your body is reacting
Right,
to it.
right.
So most of the time, I think it's not even
Like,
their
is it
fault.
my fault that you decide to go to Mexico 2 weeks after surgery and then only tell me the day after surgery? I can't control that.
Right.
Right.
Or that you, even though I ask you not to try and strain to have a bowel movement, you then do it anyway. So like these are the things that I can't control. I will say that my advice for the patient is you should always listen to your surgeon's post-operative instructions because it's a contract that you're both signing, the patient and the surgeon. The surgeon's side is to use the best judgment, right? To try and the best techniques that they know to try and do the surgery as best as possible. On the patient's side, it's listening to the post-operative instructions, trying to do everything the surgeon asks of you to give yourself the best outcome. You can't expect that if you go back to lifting heavy objects, like all of your groceries within a week of surgery, or you go run 3 miles 2 days after surgery, or you go to the pool or go to the beach like within 2 weeks of surgery, that you're going to have the best outcome. So it's really kind of a contract that with responsibilities on each side.
Right.
And I always tell my patients that it's not what happens during surgery, it's what happens afterwards. It's whether or not everything goes well and being there for the patient after the surgery.
Wow.
Yes,
I love that.
I do love
You are such a caring plastic surgeon. It has been so fun to have you on the Chattermouth podcast. Thank you, Jared, for being here, or Dr. Gopman, I should say. Thank you so much for being a part of this. This was so interesting. If you all have any specific questions for Jared, go ahead and follow him at dr.jaredgotman on Instagram, and he's very good about answering his questions there as well. Also, don't forget to follow the Chattermouth podcast and subscribe, and please leave a review. We read all of them. Anyways, thank you so much for tuning
I
in.
love this.
Me too.
Thanks for having me.
So informative, let me tell you.
Yes. Well, we'll see you all next time. Bye.